This is part two of the concept where we're discussing diabetic ketoacidosis. In a previous video, we talked briefly about the pathogenesis and clinical features of DKA, and here we will walk through the investigations as well as the diagnosis. And so in the pathogenesis, we outlined three key defining features of DKA, and that included hyperglycemia, acidosis, and ketosis. And here in the diagnosis, we're seeing these same players emerge as the criteria. And generally, the diagnosis takes a form like this on the screen, or a slight variation according to which guideline or institution or which part of the world you're practicing medicine. But no matter where you are, the criteria tend to agree on the main principles. That's acidosis with a pH of about less than 7.3, bicarb less than 15 millimoles, and some say 15 to 18. Ketonemia, and here we recall that there are two types of ketone bodies, and the one used in diagnosis is beta hydroxybutyrate, and that level must be more than 3 millimoles per liter, or if not ketones in the blood, we could accept ketones in the urine, and using a dipstick, you need significant ketones, which is 2 plus or more on the dipstick. Then we have glucose of more than 11 millimoles per liter, and which this kind of translates roughly to around more than 250 milligrams per deciliter, or known diabetes. And here we also keep in mind that some patients can present with DKA but normal glucose, and that's something we call euglycemic DKA. So that was the diagnostic criteria, and now we're going to turn to the investigations. And this here is, it's not a complete list because we don't know what the patient may present with in addition to DKA, but this should be an okay starting point. And the first three ABG glucose ketones, they make sense because it helps to clinch the diagnosis. And then electrolytes, renal function, and ECG, these are looking at fluid or dehydration status, as well as evidence of electrolyte disturbance. And the remaining investigations, like your CBC and a chest x-ray, and the ones falling in that other category at the bottom, is really trying to exclude some of the main precipitants. And as I said earlier, it's variable according to how the patient presents, and you might be wondering why a CT or MRI is there. And according to the patient's presentation, it may well be indicated, but sometimes in DKA, especially if you're suspecting cerebral edema, we might want to do a CT or MRI head. And then we are going to be speaking about the pitfalls. And when we talk about pitfalls in investigations, we're really trying to give a picture of what cannot and should not be missed when you have investigations of a patient with a diagnosis of, or suspected diagnosis of DKA. And one of the main things that we look out for is electrolyte disturbances, and particularly potassium or hyperkalemia. And we know the implications of hyperkalemia, as it could lead to fatal arrhythmias and death. And this was not explored in the pathogenesis, but in DKA, hyperkalemia could develop due to two main reasons. One, remember that ketosis is constantly occurring, and the ketone molecules are weak acids, and they dissociate to produce hydrogen ions. And these hydrogen ions, or any hydrogen ions to be honest, they tend to compete at the entry points with potassium to enter cells. And it means that when potassium leaks out of the cell, just as it's accustomed doing, when it tries to return, it now has competition from your hydrogen ions, and this gives a rise in your serum potassium. However, while the plasma might show a hyperkalemia, the cells or the tissues, they're really deficient in potassium. And we need to keep this in mind because we're going to factor this in when we're going to manage the patient with DKA. And the second reason, main reason for hyperkalemia, it could be explained from, remember what we saw in pathogenesis with a relative insulin deficiency or insulin resistance. And so insulin facilitates the transfer of potassium from the plasma into the cells. And so when it's not around or when there's resistance to insulin, as we see in DKA, the, the potassium, they could be trapped in the plasma and they can't return intracellularly. And then we have the other electrolyte disturbance, and that is sodium, which could be low or normal or high. And this is also true for potassium, by the way. But the danger with sodium is a hyponatremia. And when I say that, I'm referring to a true hyponatremia. Hyponatremia. And when I say true, it's because typically patients with DKA, they could present with a pseudo hyponatremia. And this happens because of the plasma glucose being extremely high. And this is going to pull extra water into the plasma. And by doing so, it kind of dilutes the sodium levels, which is at a fixed amount in the bloodstream. And so this is the reason why, and you will see this in a bit, but this is the reason for correcting sodium in the presence of hyperglycemia. And back to the point of hyponatremia, it's especially in the presence of a low plasma osmolarity, hyponatremia, it tends to put patients with DKA at risk for cerebral edema. And throughout the videos, you will hear me repeat this, and we'll see how we try to mitigate against cerebral edema. So that was hyponatremia, and well, patients could also have hypernatremia secondary to volume loss, and we will come back to that when we discuss the management. But the second thing is falling GCS, and this could also be a sign again of cerebral edema, and we have to try not to miss this. And then we have a long list of parameters here, and this is describing what we consider to be that of severe DKA. And that's important because if you have too many of these parameters, if the patient is, especially if the patient is not improving, or worse yet, if the patient is declining, they really need HDU or ICU support. So you really need to keep a low threshold when these parameters are heading in this direction, and you also need to apply some clinical judgment as well. Here, in calculations, you're going to recognize some of the things I was mentioned before, and that is the corrected sodium, as well as the osmolarity. As we previously stated, this kind of helps to assess the patients at risk for cerebral edema. And we keeping in mind that a low sodium or a low osmolarity, or worse yet, a combination of both of them, this is what increases the risk for cerebral edema. And normal plasma osmolarity is around 280 to 300. And of note here, which the asterisks are by, is that the corrected sodium formula is only applicable for glucose levels up to 400 milligrams per deciliter. And so if the glucose cross that level, we add 4 milliequivalents of sodium for every 100 of glucose that is above the 400 milligrams per deciliter. And feel free to slow it down or replay until you get it. All right. The other thing is anion gap, and that's something I discussed extensively in another video. So if you're not familiar with this term, feel free to check out the video on that. But this is the calculation, and we expect in DKA for there to be a high anion gap metabolic acidosis. And then here is the corrected gap, which can be affected in cases of nutritional deficiencies. And so albumin is factored in to correct that. And well, this kind of brings us to the end. And we discussed the diagnosis. We discussed the investigations involved and their significance, as well as here some useful calculations that can be employed in DKA. And so in the next video, we will begin to discuss the management of DKA.